Good. I think we're good to go. Good afternoon, everyone. For those of you who don't know me, my name is Hannes Koornhof, and I'll chair this session, although we're here from a cold and windy and almost rainy, if I look at it, Cape Town. So today's about CLL, and to get some perspective with regards to some of the treatments, how to approach some of them and how do you choose. And Michael Kaz is our speaker today, and I'll introduce him shortly. Just a couple of housekeeping rules. As you know, all the recordings can be found afterwards on Blood SA's website. Any questions, please put them in the chat box. We'll try to look at them and address them as we go along. As you know, CPD accredited, but you need to stay for at least 60 minutes. And just make sure that you are individually logged in and not as a group. And for any queries, please contact Melanie at UCT. There is our fantastic management team, and I just want to honor them for their all their persistence in keeping Deep Dive ongoing through all the years and the months that it has been. It's really been a breath of fresh air with regards to hematology. And yeah, Estelle, Gerdine, and Melanie, thank you very much for all the effort that you guys are going on to try and keep hematology together. Just a bit of an opportunity to remind everyone and to invite you to come to Cape Town in September, our annual HemOnc conference. Yeah, it's going to be great. I'm not going to let the cat out of the bag. We'll probably soon send an email with regards to all the speakers. There's a lot of great speakers, a lot of great topics. It's at the Lord Charles Hotel. So come and join us in September. It is our one big annual society-driven conference where we really try and focus on high-level discussions, not pharma-driven, where we really can just sit and chat to each other about things in depth with the speakers. Yeah, I think it's a nice social event to be able to bond with each other and get to know each other better as well. So please come and join us. So as I said, the agenda is with regards to CLL treatment for this week. Next week, intermediate risk AML. So that is quite a loaded topic. So join next week for that as well. So Michael is talking about CLL. There's quite a lot written about him there, you can see. I've known Michael since first year in varsity. He's not only a great person, but a great hematologist. I'm not going to read all of that stuff, but Michael, after graduating at Stellenbosch pre-grad, he went to Barra to do his internship. And seemingly as a recurrent topic, he longed back to Cape Town. So he came and spent a couple of years in Paarl and then did internal medicine and clinical hematology at Tygerberg many years ago, and then joined our colleagues up in Pretoria East at ActLife for 5 years. And then the Western Cape winked again and lured him back here. And we are thankful that he's joined us here at Hemalife, where he's really been a massive asset. Michael is very passionate about various conditions, but especially about newer developments and newer drugs and making getting more patients access to newer medications. He started the clinical trial center here at Hemalife as well. And we are very thankful for all his skills. And we're looking forward to, Michael, to what you are going to teach us this afternoon. The floor is yours. Yeah, welcome to Deep Dive. We look forward to what you have to say.
Thank you very much for that kind introduction, Hannes. It's really been a fantastic year and a half back in the Western Cape, and fantastic to join a dynamic and steadily growing and developing and evolving team at Hemalife. It's a team of really passionate people, and I'm very proud to be a part of it. It's my debut presenting a deep dive today. I have attended a couple of deep dive talks, and they without fail have been high quality. So I feel a bit under pressure here to perform. I'll do my level best. CLL is a topic about which I feel quite passionately. It's a subject which I think a couple of years ago was fairly simple and straightforward, and it's been growing in complexity ever since the better understanding of the biology determined by the IGHV status and how that impacts treatment selections. And I think until a couple of years ago, the big question in CLL was, does this patient get standard chemoimmunotherapy, or does this patient need a novel agent? And I think that question has been fairly satisfactorily answered. But I think we're now in an era where there are a substantial number of different options in terms of novel therapies, and there are different treatment strategies as well. And these have really been evolving into two groups. And the first is a fixed duration type of treatment, and the second is a continuous therapy type of treatment. And here in South Africa, we always grapple with using novel therapies. Who can we get access for? It's usually limited to high tier options on medical aids. Obviously, many of these drugs are not at all available in the state sector. Cost is a huge question, even in the private sector. So how do you take this decision, and how do you choose clinically the most appropriate option? And I think I'm going to try to provide answers to some of those questions today. I've entitled the fixed duration approach Fast and Furious, and I've entitled the continuous therapy approach Slow and Steady. Now, while a bullet train looks far sexier than this powerful diesel engine, the diesel engine can certainly do many things the bullet train can't. So let's dive in. These are my disclosures. I just put this up here to say that I've received honoraria for doing talks and participating in ad boards from the three major pharmaceutical industry players in the CLL arena. So I'm not particularly biased in any direction. I have not been paid an honorarium to present this talk today. And I'm just putting an important disclaimer here. I'm going to do something that you all know is highly illegal, and that's to compare trials to each other. So there's a lot of inter-trial comparison and educated guesswork at play to draw some of the conclusions that I will at the end of this talk. What I'm going to cover, I'm going to go through the guidelines quickly. There are a couple of different guidelines I'm going to look at. There are some subtle differences which are interesting. So that just shows you what other people elsewhere in the world are doing. I'm going to go through some of the important trials, because the data that came from those trials is what I'm going to use to draw my conclusions. And then I'm going to round off with this debate about fixed duration versus continuous therapy, which is better, which should we be using, and why. So let's start off with the guidelines. So this IWCLL first-line treatment options was published in 2019. So it's a little bit dated. I'm sure you'll recognize this table, though. Michael Halleck from the German CLL study group always presents his treatment approach in these kind of tables. So that's essentially where it came from. I've added these purple things on the right-hand side because I think up until relatively recently, this is basically what we were doing. And obviously, if the patient was asymptomatic, what their deletion 17p status or their fitness or their IGHV status was irrelevant because they didn't need therapy. If they did have active disease or advanced stage disease, then they did need therapy. And then the most important thing to know was whether they had a TP53 aberration. So I'm going to use that term TP53 aberration to collectively refer to deletion 17p by FISH or TP53 mutations by PCR or NGS. So if they had a TP53 aberration and they needed treatment, then what their fitness was and what their IGHV status was relatively irrelevant because they needed a novel therapy. Those were fairly well tolerated, so hence the irrelevance of fitness, although that's always relative. And ibrutinib or venetoclax and obinutuzumab were the preferred options. The red highlighted venetoclax and obinutuzumab is on the basis of what is preferred in Germany. And the reasons for that are varied. Idelalisib and rituximab increasingly falling out of favor, but it is available in certain countries if there are contraindications to ibrutinib. If they did not have a TP53 aberration, then their fitness was relevant and you had to decide how fit they were. And you also had to determine what their IGHV mutation status was. So in 2019, for someone who was fit and had IGHV mutated CLL, FCR was the treatment of choice. And if they were older than 65, then bendamustine and rituximab. Of course, ibrutinib could be considered in that group as well, depending on the circumstances. If they had IGHV unmutated disease, they needed to have ibrutinib. They still included FCR at that stage in the guideline, or bendamustine and rituximab for older patients. If they were unfit, then really venetoclax and obinutuzumab was the treatment of choice for both of those categories. If they were IGH mutated, then a chemoimmunotherapy approach could still be employed. Although in this specific guideline, it is included under the unmutated section as well. In South Africa, really access to novel therapies at that stage was so limited, we were still very much using chemoimmunotherapy. In some cases, drugs like alemtuzumab, and we definitely have considered allotransplants if a patient was young enough for TP53 aberrated patients with CLL. Certainly the slow-go setting, monotherapy rituximab or rituximab and chlorambucil. So that was the IWCLL guidelines. What are they doing in Germany? So this is a more updated guideline. It's the German Oncopedia, which they use to treat CLL in 2023. So again, similar initial approach. You need to decide whether the treatment is indicated or not. And then they start off on the left-hand side. If you don't have a TP53 aberration, then your IGHV status is important. And what's interesting, and you can just glance over those treatment options under both the IGHV mutated here on the left-hand side and the IGHV unmutated on the right-hand side, you'll see no mention of chemoimmunotherapy at all. So in Germany, chemoimmunotherapy for CLL is a thing of the past. They are exclusively using novel therapies. For patients with IGHV mutated disease, obinutuzumab and venetoclax is the preferred option, but they list the BTK inhibitors as alternatives with or without anti-CD20 monoclonal antibodies. If the third option is a combination of ibrutinib and venetoclax, and that's based on some of the trials I'm going to show you in some slides to come. If you are IGHV unmutated, however, then acalabrutinib and obinutuzumab or zanubrutinib or a combination of ibrutinib and obinutuzumab were the preferred options. If those were not available, or if there was a contraindication for some reason, then obinutuzumab and venetoclax listed as the second option and ibrutinib and venetoclax as the third option. If, however, you had a deletion 17p or TP53 mutation, they recommended first-line treatment with a BTK inhibitor, and I'll come to why that is as well. But obinutuzumab and venetoclax listed as an alternative as well. For really unfit patients who are unable to tolerate novel therapies, best supportive care is the approach. These are the ESMO guidelines. They're also a little bit out of date, 2020. Again, they divide patients into TP53 mutated and no TP53 mutation, and then the IGHV status is more important. IGHV mutated patients without TP53 mutations, they still considered FCR to be a possibility at that stage. So that's the difference with the current German guideline. This is the NCCN guideline, which is also fairly new. It was updated earlier this year. And what's interesting to me is they actually completely ignore the whole IGHV mutation story. They focus on the presence or the absence of a TP53 mutation. What is quite nice is they give you quite a clear plan for sequencing novel therapies. So if you started off with a BTK inhibitor, depending on what your reason is for discontinuation, whether you've become intolerant or whether you've had progression on treatment, they advise alternatives. But really, chemoimmunotherapy is mentioned here at the bottom of the slide, and it's really the last option, but still appears on the guideline. Whereas for patients with TP53 aberrations, the preferred regimens are the BTK inhibitors, acalabrutinib plus obinutuzumab, but they do include venetoclax and obinutuzumab and zanubrutinib there as well. And then this box shows you the second and subsequent line therapies. They mention the other recommended regimens here as well. So quite a lot of correlation between the different guidelines. There are some differences. There is some controversy as to whether chemoimmunotherapy still has a place in the treatment of CLL and exactly where that is. So from my perspective, I think these are the important trials looking at first-line therapies in CLL. I think we're all very familiar with FCR, and its use in CLL is primarily based on the very important CLL-8 trial, which commenced many years ago. The 8-year follow-up was published in 2016, so very mature data for FCR. The bendamustine and rituximab regimen based on the CLL-2M trial and the MABEL trial. Ibrutinib, quite a lot of data from 3 different first-line trials, Resonate-2, Alliance, and E1912. Venetoclax, and particularly in first-line, venetoclax in combination with obinutuzumab is largely based on the CLL-14 trial. And then the newer trials with the relatively newer agents, acalabrutinib first-line based on Elevate-TN, TN standing for treatment naive, zanubrutinib first-line data from the Sequoia trial. And then I'm going to show you some combination trials, Captivate, Glow, and CLL-13. So let's kick off and look at the data. So this is the crowded space that first-line CLL trials have become. So I'm sure that most of you will have seen these graphs many, many times in CLL presentations before. This specific data is from the long-term 8-year follow-up, which was published in 2016. And really, all I want to emphasize here, so just for those of you who are not familiar with CLL-8, it was FC versus FCR. So really, it was a trial to demonstrate the benefit of the addition of rituximab to the chemotherapy backbone and what difference that could make. And this graph on the left-hand side just demonstrates the massive difference that having a TP53 aberration makes. Both trial arms did significantly worse with TP53 aberrations. What I really want to show you here is on the right-hand side, though, and that's the progression-free survival of the patients who received FCR who had IGHV mutated CLL. And this is really why FCR and chemoimmunotherapy have remained such an important part of CLL guidelines for IGHV mutated CLL patients. And as you can see here, at this 8-year follow-up, this curve appears to have reached a plateau, which may mean that nearly 60% of patients in that specific subgroup have potentially been cured of their CLL. FCR is a difficult-to-use regimen and comes with many long-term problems and complications and secondary malignancies. So there is a bit of a payoff in terms of that. But nevertheless, in that subgroup, it does well. And you can see here at 8 years in excess of 80% overall survival for that subgroup of patients. That brings us to the CLL-2M trial. So in the FCR era, highly intensive regimen fraught with problems during therapy of severe neutropenia and episodes of neutropenic sepsis, considering that the mean age of diagnosis at CLL is 67, most patients being too old to tolerate a regimen like FCR, something was needed for older patients. And rituximab and bendamustine emerged as an option for this. It didn't show benefit above FCR in younger patients, but certainly in older patients, it appeared to be more tolerable with fewer side effects and reasonable efficacy. And even today, where it's used as a comparator, I'm going to show you in some of the later trials, very, very few situations have been proven to have an overall survival advantage over a regimen like R-Benda. I think as a consequence of the novel therapies being so well tolerated in older, less fit patients, R-Benda is increasingly falling by the wayside. But in a country like South Africa, where many of our patients are not going to have access to novel therapies, it's really a good alternative in those situations. This graph on the right-hand side here, again, just illustrates the very poor outcomes in patients with TP53 aberrations with CLL. Next, we come to the Resonate-2 trial. So the Resonate-2 trial was a clinical trial which compared ibrutinib with chlorambucil. It seems like a poor comparator arm from our perspective in 2023, but at the time that this trial was designed, chlorambucil was basically the standard of care for older patients who were unable to tolerate FCR. So these were older patients. They were ineligible for intensive therapies like FCR, and they had comorbidities. And just to say that RESONATE-2 also allowed crossover from the chlorambucil arm. Patients who progressed on chlorambucil were allowed to cross over to the ibrutinib treatment arm, but they were not included in all of the analyses. So it's very difficult to prove an overall survival advantage with the new therapy when you allow crossover in a clinical trial. But progression-free survival, I think, is an important marker in CLL trials. And you can see this curve on the left-hand side, which demonstrates the very significant difference in overall survival. Even at this 8-year follow-up, median progression-free survival for the ibrutinib arm has still not been reached. So quite a dramatic difference there. The right-hand side slides demonstrate the subgroups with higher risk genetics. So the graph on the right-hand side at the top demonstrates the differences in the deletion 11q. So we know 11q similarly, but not to quite the same extent as TP53 aberrations, also confers a slightly worse prognosis, which is abrogated by ibrutinib therapy. Chlorambucil does not overcome the negative prognostic effect of having an 11q mutation. In the curve on the bottom right-hand side, we look at the IGHV status, and where you can see a separation for the two chlorambucil curves between mutated and IGHV unmutated CLL, as we would expect with chemotherapy. You can see that the two curves for ibrutinib in both the unmutated and the mutated groups are very much superimposed on each other, demonstrating that ibrutinib overcomes the negative prognostic implication of IGHV mutation. Next, we come to the Alliance trial. So Alliance also looked at older patients with CLL, and this was first-line therapy. I think because of the criticism of chlorambucil being an outdated standard of care for older patients, they wanted to use R-Bender, which had become the standard of care for older patients. So it was a better comparator arm to use. It was also interesting that the two study arms were different. The one was ibrutinib monotherapy, and the second arm was the combination of ibrutinib and rituximab. And you can see that those two curves at the top on the left-hand side are virtually superimposed on each other. Adding rituximab to ibrutinib monotherapy confers no additional advantage in terms of progression-free survival. But again, a substantial difference in terms of progression-free survival with quite a split in those curves. And again, the advantage for ibrutinib over rituximab and bendamustine was seen in all subgroups of patients treated. And that included both IGHV mutated and unmutated CLL. So that's why most countries where access to a drug like ibrutinib is fairly easy, they would prefer ibrutinib monotherapy, even in IGHV mutated CLL in older patients. But as you can see on the right-hand side, very little difference, and certainly no statistically significant difference in overall survival between the three arms. So where you can't get access to ibrutinib for patients, R-Bender is still a reasonable option, as it will confer similar overall survival. This is the E1912 trial. So I think both Alliance and RESONATE-2 had demonstrated ibrutinib's efficacy in older patients who were ineligible for more intensive options. The question was now, does ibrutinib produce the same advantage over FCR in younger patients who would be eligible for FCR? And this is the 7-year updated follow-up published in 2022. And here you can see that that ibrutinib-based therapies are superior in progression-free survival in various different subgroups. The one question was, and when this trial was initially announced, the results of this trial were initially announced at ASH in 2018. The follow-up was at 3 years, and there was no difference in the outcomes in the IGHV mutated group. With longer-term follow-up, a difference has now emerged, and there is a progression-free survival advantage for ibrutinib over FCR, ibrutinib and rituximab combination, that is, over FCR in patients who are younger than 65 and who have IGHV mutated CLL. So another reason why the Germans have probably eliminated chemoimmunotherapy entirely from their treatment algorithm. Okay, which brings me then to CLL14. So we leave the BTK inhibitor space for a moment and move to the BCL2 inhibitor space. So CLL14 also looked at first-line therapy, and this was also in older patients, less eligible for intensive chemotherapy. The comparator arm to the venetoclax-obinutuzumab combination was chlorambucil and obinutuzumab. This is the updated 6-year follow-up, which was announced last year at EHA. The dark blue lines are the two venetoclax and obinutuzumab arms, and the lighter blue arms are the venetoclax, I apologize, the chlorambucil and obinutuzumab arms. The top curves show you the difference in outcomes in TP53 mutations. And as you can see, patients without TP53 mutations who receive venetoclax and obinutuzumab do extremely well. And there is superior outcomes for patients with TP53 mutations, but there is a significant separation in those two curves. So venetoclax and obinutuzumab does not completely overcome the negative prognostic impact of TP53, not in terms of progression-free survival. And a similar finding is true for the IGHV status. So obinutuzumab and venetoclax performs extremely well in patients with IGHV mutated CLL, as you can see by that top dark blue dotted curve. But again, there's a separation in the curves for the venetoclax and obinutuzumab treated patients with IGHV mutated CLL. Now, just remember, when comparing this trial in your mind, which I'm going to do a little bit later for you graphically, to the continuous therapy with ibrutinib, that these patients only received treatment for 12 months. So treatment stopped just at this point on the 12-month mark on this curve. So it's round about then that you start seeing the separation in the curves more distinctly. So the question is not, is ibrutinib a superior drug to venetoclax? The question is continuous therapy a superior strategy to fixed duration therapy? And I think that's very important to take note of. Next, we come to the Elevate-TN trial. So Elevate-TN looked at a next generation, well, acalabrutinib is referred to as a next generation BTK inhibitor. It is not strictly speaking a second generation BTK inhibitor. I will talk about second generation BTK inhibitors briefly at the end of the talk. So acalabrutinib, slightly different molecule, works in the same way, binds to the same part of the BTK enzyme as what ibrutinib does. There are some advantages to acalabrutinib over ibrutinib, and we'll talk about those a little bit later as well. The Elevate-TN trial used obinutuzumab and chlorambucil as a comparator arm, similar to CLL14, but this was continuous therapy with acalabrutinib after the initial period of treatment with obinutuzumab. Again, you can see a separation in the curve starts here around about the 12-month mark, and that's probably because of the end of fixed duration treatment on the control arm. What is interesting here is that the addition of obinutuzumab to acalabrutinib actually produced a further benefit. So whereas rituximab added to ibrutinib in the E1912 trial did not produce additional benefit, here obinutuzumab looks as though it may well do so. The second curve demonstrates the outcomes in patients with TP53 mutations, and acalabrutinib is confirmed to completely abrogate the negative prognostic effect of TP53 mutations, as what ibrutinib does, whereas those outcomes are inferior in patients treated with chemoimmunotherapy. And the bottom curve demonstrates the difference in outcomes with IGHV status. Here you can see there's a dramatic separation in the obinutuzumab and chlorambucil arms, with mutated patients, IGHV mutated patients, performing nearly as well in terms of progression-free survival as the study arms, and those with IGHV unmutated disease performing extremely poorly. Nevertheless, both the acalabrutinib arms had statistically significantly superior outcomes to the study arms in both the IGHV mutated and unmutated groups. Next, we come to the Sequoia trial. So Sequoia looked at another next generation BTK inhibitor, zanubrutinib, and its use in first line in older, less fit patients. By this time, it was well established that TP53 mutations were associated with very poor outcomes in patients treated with chemoimmunotherapy. So though they compared zanubrutinib to bendamustine and rituximab, patients with TP53 mutations were actually excluded from this analysis, which is cohort 1, or this group of patients, which was cohort 1. So this included no TP53 mutations, but you can see the superior outcomes in progression-free survival with zanubrutinib over bendamustine and rituximab. They had a second arm. In fact, they had a third and fourth arm to the study, but I'm not going to go into those in details, but they had a second cohort in which they did include patients with TP53 mutations. It was just a single study arm. There was no comparator, and this demonstrates very good progression-free survival, as is seen with other BTK inhibitors in patients with TP53 mutations. So hopefully I've convinced you by now that BTK inhibitors are very good in the setting of TP53 mutations and tend to abrogate the negative prognostic impact. Next, I'm going to talk about some combination trials. So Captivate was a clinical trial that explored fixed duration combination of ibrutinib plus venetoclax. And this bar chart on the bottom left-hand side, so really it was a single arm study looking at this combination. It was a phase 2 clinical trial. And just to demonstrate that there was really very little difference in terms of the response rates between patients who had TP53 aberrations and the whole group. So just as good outcomes with the combination. And this is just a progression-free survival curve, which demonstrates that, that again, TP53 aberrated patients had equal outcomes to the rest of the cohort. This is follow-up at 27 months, and the treatment period was only the first 12 months. So it does appear that in the longer term, the positive effect of this combination treatment is preserved. I think we need further data maturity to see what's going to happen in the longer term, and is there a separation of those two curves? Because it does appear that in patients with TP53 aberrations, if you use fixed duration therapy, the curves do tend to separate over time. And that's why it's a strategy-based debate rather than a drug-based debate. Next, I'm going to tell you about CLL13. So this was another combination trial. It used a comparator, it used a control arm of chemoimmunotherapy, which was really based on investigators' choice and age. Patients who were younger than 65 and fit were treated with FCR. Patients who were older than 65 or were unfit or had comorbidities were treated with bendamustine and rituximab. There were then 3 study arms, the one a combination of venetoclax and rituximab, the other a combination of venetoclax and obinutuzumab. Then the third study arm was a combination of 3 drugs, venetoclax, ibrutinib, and obinutuzumab, equal numbers in each study arm. And these were the progression-free survival outcomes. So the top 2 curves, the black line over here is the combination of the ibrutinib, venetoclax, and obinutuzumab, and the red line is the venetoclax and obinutuzumab combination. So no statistically significant difference in outcome between those 2 arms. But I think this study shows that obinutuzumab in combination with venetoclax is clearly superior to venetoclax in combination with rituximab, and chemoimmunotherapy has significantly poorer outcomes than those combinations. What is interesting is to see here is how these curves of venetoclax and rituximab and the chemoimmunotherapy come together. Again, there's no differentiation in this specific curve with TP53 aberrations and with IGHV mutations. That data is still eagerly awaited and will hopefully be presented at this year's EHA meeting. This is the GLOW study. Another combination, fixed duration combination therapy regimen. So these patients were given ibrutinib and venetoclax for a period of 14 months, and the control arm patients were treated with chlorambucil and obinutuzumab for 6 months. So again, quite a difference in terms of the length of treatment. Interestingly, these curves only started separating not at the end of chlorambucil and obinutuzumab, but at the end of the venetoclax and ibrutinib treatment arm. And you can see the significant difference in the progression-free survival, again demonstrating a high efficacy in terms of superior progression-free survival with the ibrutinib and venetoclax regimen. So another way to give fixed duration therapy. Okay, so which brings us to the important question that I want to ask our group this afternoon. What is the best first-line strategy? Is continuous therapy the best first-line strategy, or is fixed duration the best first-line strategy? So to try to answer this question, I'm going to compare some trials. I'm going to first start with fixed duration therapy with FCR. So FCR was our original bullet train, the TGV in France, if you like. This image is actually of the relatively newly implemented first bullet train in India. So one of the most modern bullet trains in the world. So FCR was our first bullet train, first fixed duration therapy, first thing that really brought about exciting outcomes in CLL. But in 2023, we need to ask ourselves who actually benefits from FCR. Well, remember that at the time of diagnosis with CLL, probably about a third of patients actually don't have an indication for treatment. So we're obviously not going to give them any kind of treatment at all. And when you consider the patients who are older and have comorbidities and are not eligible for an intensive treatment like FCR, that takes probably another 60% of patients. When we include those patients who can't get FCR because they've got an unmutated IGHV status and possible other gene abnormalities, that takes us up to about 90%. And then patients who are treated with FCR who have MRD positivity at the end of treatment, and we know from the CLL8 trial what an important marker MRD positivity by flow cytometry was, really at the end of the day, it's only about 7% of patients with CLL who will benefit from FCR. The other problem is increased incidence of secondary malignancies. And I think we've all seen CLL patients treated years ago with FCR who now present with myelodysplastic syndromes and acute myeloid leukemia. CLL is a disease that confers an increased risk of other solid tumors to begin with, and now you add fludarabine into the mix, which further increases that risk. So I think the real problem with using something like this is the risk of secondary malignancies, which can affect up to 20% of patients treated with FCR. And then, of course, there's the data from the 7-year follow-up from the E1912 trial, which demonstrates that the ibrutinib and rituximab combination has become statistically significantly superior to FCR in that subgroup in the CLL8 trial that did well, those with IGHV mutated disease. So I've just included that progression-free survival curve here from the CLL8 trial. So this is my first illegal maneuver for the afternoon, comparing different trials. I just thought it was interesting that you could have a look at this FCR curve in the E1912 trial and see that at the 7-year follow-up, the progression-free survival was around about 60%, which is exactly what it was in the CLL8 trial. So that confers some confidence in the control arm of the E1912 trial. It probably means that this is real, that ibrutinib and rituximab is a little bit better than FCR in terms of treating IGHV mutated CLL. What about fixed duration therapies with venetoclax and anti-CD20 monoclonal antibodies? So that's the other bullet train approach. So I've shown you the CLL 14 data, the 6-year follow-up, which really demonstrates that in that group of IGHV mutated CLL patients, this combination does really, really well. It does outperform chemoimmunotherapy in terms of patients with TP53 aberrations, but there is a significant separation of the curves. It does not completely abrogate the negative prognostic effect of TP53 aberrations. It's also better than chemoimmunotherapy in terms of IGHV unmutated status, but again, this problem of the separation of the curves. And again, I'm just putting in that slide from E1912 to show you the outcomes in IGHV mutated patients look fairly good in this trial, but fairly comparable as well to the venetoclax or brentuximab combination in IGHV mutated CLLs. This is the time to next treatment from the CLL14 trial, and this is now 5 years post-randomization, and significantly different to the chemoimmunotherapy option. So really a good fixed duration option by comparison to fixed duration chemoimmunotherapy. We know that in venetoclax-based treatments, MRD negativity as a target of therapy is important. Patients who achieve MRD negativity really do fantastically with venetoclax-based regimens, whereas those who remain MRD positive do a lot more poorly. This is not such a factor with the BTK-based inhibitor regimens. We know that many patients treated with BTK inhibitor monotherapy remain MRD positive, and it does not confer a worse prognosis. Overall survival in the CLL14 trial. So an overall survival advantage could not be shown, but I draw your attention to the right-hand side of this curve, which does look like there's a separation is starting to develop, but it is not yet statistically significant. It will be interesting to see what happens with longer follow-up in CLL14. Okay, and then we've got an ultra new bullet train, and that's fixed duration therapy with ibrutinib. Was there a question or a comment? Somebody's mic's on. Okay.
Michael, just unmute yourself quickly. I just muted everyone, so if you could just unmute yourself.
Got it. So looking at the venetoclax and ibrutinib combination. So I showed you data from Captivate, that was I plus V, and the GLOW trial, which was also I plus V versus chlorambucil and obinutuzumab, and then most recently the CLL13 trial, which the study arm was ibrutinib, venetoclax, and obinutuzumab. So I don't think ibrutinib, venetoclax, and obinutuzumab or ibrutinib and venetoclax has really shown superiority over venetoclax and obinutuzumab at this stage. And venetoclax and obinutuzumab certainly the more cost-effective combination from the South African perspective. It will be interesting to see what develops, and what will also be interesting to see is what are the different differential advantages in the IGHV unmutated and TP53 groups. So hopefully that data will be available soon. So I've shown you the advantages of fixed duration therapy now, and obviously in a country like South Africa, fixed duration therapy costs less. So that's a very important consideration. So really considering that overall survival advantages are not present for any combination, and not even above a combination like Arbenda. What else is important? Well, I always say to people, and particularly representatives from medical aids, when they tell me that a specific combination doesn't have an overall survival advantage, that in a disease like CLL, which has a very good prognosis to begin with, and the fact that we now have very effective therapies available, it's actually virtually impossible to show an overall survival advantage. Patients are allowed to cross over in clinical trials. There are effective salvage regimens, and particularly in countries where these clinical trials are being performed, that's mainly in the Northern Hemisphere, patients have access to various different salvage options. It makes producing an overall survival advantage virtually impossible in a clinical trial. So I think for a disease like CLL, progression-free survival really is an important parameter. So should we be using the diesel steam engine in place of the fixed duration therapy in some situations? It is going to turn out to be more expensive. So I think it's important to know whether there's a good clinical reason for doing so. And to my mind, really the major advantage and the important use of continuous therapy is in the setting of TP53 mutations. So I'm now going to perform another illegal maneuver and compare these two trials. On the left-hand side, we've got Resonate-2. So I remind you that was a first-line trial in older patients who were ineligible for more intensive therapies like FCR. And they were treated with first-line either with ibrutinib or chlorambucil. On the left-hand side, I'm showing you here just the outcomes with the ibrutinib-treated patients. The top curve is the overall survival curve. The bottom curve is the progression-free survival curve. On the right-hand side, I've got that graph from the CLL trial again. And in particular, I'm showing you the curves demonstrating patients with TP53. Sorry, this is the subgroup of patients, particularly with TP53 mutations, treated on the RESONATE-2 trial. So let's just have a look at what happened at 3 years of follow-up in these studies. So I've used 3 years as a marker because this is the current follow-up that's available for the CLL14 trial for the subgroup analysis. So at 36 months, for patients who were treated with venetoclax and obinutuzumab who had TP53 mutations, the progression-free survival was about 60%. If we look at the RESONATE-2 trial, at 3 years of follow-up, that's same group of patients with TP53 aberrations, the progression-free survival was 85%. So 85% versus 60%, I think that's quite an interesting difference. Now, the reason why we don't compare clinical trials to one another is because we don't know what the different populations were like. We can look at the table 1s of the clinical trials and try to determine if the patient groups are similar, but even doing that is not good enough. So a huge disclaimer and proviso with this comparison. To my mind, it looks quite significant though. What about IGHV mutation status? Is there a difference there? So I looked first at the relapsed and refractory setting to try to answer that question. So the first RESONATE trial was in patients with relapsed or refractory CLL, and that was ibrutinib monotherapy versus ofatumumab monotherapy, that other anti-CD20 monoclonal antibody that's not really widely used. And the Murano trial was the venetoclax and rituximab second or subsequent line therapy versus bendamustine and rituximab second and subsequent line therapy. Now, I again draw your attention to the fact that these 2 curves in RESONATE, so these are the ibrutinib-treated patients with both mutated and unmutated CLL, overlay each other completely. There's absolutely no separation in the curves. Yet, if you look at the follow-up, so I have made the follow-up roughly the same on both of these. Oh, that graph is not in the right place. It should be here. But anyway, it doesn't make a difference. This progression-free survival at that time is the same. So, oh, sorry, it was 50% progression-free survival. So the 50% progression-free survival for these 2 trials is very similar. What was interesting to me was that even though in the ibrutinib-treated patients, one would have possibly expected the progression-free survival to be a little bit better based on the first-line data. And I explored the table 1s of both of these trials to try to find the reason for that. And really, the only thing that I could find is that the ibrutinib-treated patients in the RESONATE trial had more prior lines of therapy. So a median of 1 to 12 prior lines of a range of 1 to 12 prior lines of therapy with a median number of prior lines of therapy of 3. 53% of patients had 3 or more prior lines of therapy, whereas the majority of patients included in the Murano trial had only had 1 prior line of therapy. So that's the proviso to interpreting this comparison. So I was intrigued and I went and looked at what did the first line data look like. So first line trial equivalents of both of those trials are RESONATE-2, chlorambucil versus ibrutinib, and CLL14. Venetoclax obinutuzumab versus chlorambucil obinutuzumab. So if we do the same exercise here and look at the 72-month or 6-year follow-up data and look at what the progression-free survival is for the IGHV unmutated patients treated with the study arms, you can see for the ibrutinib patients, it's a little bit over 60%, whereas for the venetoclax obinutuzumab patients, it's a little bit over 40%. So here again, it looks like continuous therapy with ibrutinib may have an advantage over the fixed duration therapy with venetoclax and obinutuzumab. If we look at progression-free survival in these trials, and all of the different novel therapy trials have been included in this slide here. I haven't really spoken about the Illuminate trial today. That was a study looking at the combination of ibrutinib and obinutuzumab wasn't quite as impressive a difference as in the acalabrutinib plus obinutuzumab arm. And really, you can see all of these trials exhibit very similar progression-free survivals if we don't differentiate subgroups. And bearing in mind that, yeah, you stop treatment for the venetoclax-based treatments, but all of these other trials with continuous therapy, patients continue to be on therapy for years and years and years. And the question is, what is the impact on patient experience by remaining on therapy for so long? The other factor that we have to consider in terms of comparing fixed duration therapy versus continuous therapy is that patients on fixed duration therapy spend a lot less time on drug than patients on continuous therapy. And if they're not on drug, then they're not being exposed to any kind of adverse effects. And certainly adverse effects may be minimal. And for many of the drugs used for continuous therapies, the adverse effects are fairly minimal and fairly tolerable. But nevertheless, they do have an impact on patients' quality of life. So if you use a fixed duration strategy approach, you give 12 months of, for example, venetoclax and obinutuzumab, and then the patient may spend years and years of therapy. The other thing to remember is that the way clinical trials define disease progression is maybe an increase in the lymphocyte count, or maybe the development of lymphadenopathy, but that doesn't necessarily constitute an IWCLL indication for treatment. So they may have disease progression, but may be able to remain off treatment for up to another year or two before they do develop an indication to restart treatment. And then they can again be treated with a type of fixed duration therapy, go back into remission, and again remain off treatment for a considerable period of time. So another significant advantage of the fixed duration therapy option is the substantially longer period that the patient spends off treatment. For a patient who receives the continuous therapy approach, they're continuously on drug for 5, 6, 8 years, for as long as what they are responding and not developing side effects. And at the time that they develop progressive disease, so if you look at the NCCN guideline, and other guidelines are designed similarly, if you start off with a BTK inhibitor continuous therapy and you have disease progression, then you switch to a fixed duration therapy with venetoclax and obinutuzumab, and then you go into remission, and then you have a period of time of treatment. Of course, you may have a lot longer on your initial continuous therapy, and by the time you progress after your fixed duration therapy, you've had very little time off drug. So that's a substantial disadvantage of the continuous therapy approach, is that patients really spend most of the time on drug, most of the time being exposed to side effects. And I think, as is apparent from the ibrutinib data, yes, most patients only had grade 1 and 2 adverse effects, but there was a litany of adverse effects, and all of those could impact on patients' quality of life. But just in terms of safety and in terms of quality of life, I'd just like to take you through some slides looking at the relapsed refractory data. So this is the Alpine study. So this is patients being treated with zanubrutinib versus patients treated with ibrutinib. So the Alpine study used a control arm of ibrutinib to demonstrate the efficacy of zanubrutinib. And on the left-hand side in this graph marked A, you can see the difference in progression-free survival in patients with zanubrutinib versus those treated with ibrutinib. But I think what was particularly interesting to me was this top right-hand curve, where we see a statistically significant difference in the progression-free survival of patients with TP53 aberrations treated with zanubrutinib. So zanubrutinib has now demonstrated itself to be the BTK inhibitor that is superior to ibrutinib in terms of treating patients with TP53 aberrations. No difference in overall survival at this stage demonstrated. And so the Elevate-RR study was now second or subsequent line acalabrutinib in terms of the treatment of CLL. And again, the control arm here was ibrutinib. These curves just demonstrate the progression-free survival and the overall survival. And you can see, unlike with zanubrutinib, there's no difference here between the outcomes of patients treated with acalabrutinib and ibrutinib. So acalabrutinib has at least proven itself to be non-inferior to ibrutinib in terms of outcomes. But where the difference does lie is tolerability. So we know that the issue with BTK inhibitors in general is the problem of atrial fibrillation and hypertension. And these curves demonstrate that patients treated with acalabrutinib, the differences are small, but nevertheless statistically significant. And I think for the hypertension, the difference is a little bit more significant. There were lower incidence, lower rates of these adverse effects in patients treated with acalabrutinib. So certainly non-inferior to ibrutinib and a safety advantage over ibrutinib. Okay, so that brings me to my conclusions. And again, I'm going to repeat that disclaimer that I made at the beginning of this talk. These conclusions are based on comparing different trials to each other, which is highly illegal to do in academic medicine. But where we don't have clinical trials which compare two therapies directly, unfortunately, we are compelled to do these kind of exercises. I really think that the very first thing that you need to take into account when deciding on either a continuous therapy or a fixed duration therapy is the patient's circumstances. What is their general condition like? Obinutuzumab and venetoclax may not be as intensive as FCR, but patients do sometimes become quite significantly neutropenic on that combination. Yes, there are good strategies to manage that. In patients with abnormal renal function, you do have a higher risk of developing tumor lysis syndrome. The strategy of starting the obinutuzumab prior to introducing the venetoclax appears to have abrogated that, and there's a lot less tumor lysis, but nevertheless an important thing to consider. What comorbidities do they have? Do they have atrial fibrillation, and are they on an anticoagulant? May influence your decision to use a BTK inhibitor. It's not a contraindication to using a BTK inhibitor, but remember that BTK inhibitors cause a degree of platelet dysfunction, and if you add an anticoagulant into that mix, then you may have more significant bleeding episodes. What is their distance from the treatment center? South Africa is a large country. We have hematology centers, unfortunately, only in the largest cities. Many patients have to travel hundreds of kilometers. For a patient who is on a treatment like venetoclax and obinutuzumab to have to come to the treatment center weekly for the first cycle may be fairly difficult. And especially if they need to be admitted for a few days, it can be quite a difficult challenge. So a continuous therapy in a patient like that may be a more optimal choice. So I really think that the very first thing you need to consider is what is the patient's circumstances. In patients with TP53 aberrations, my opinion is that a BTK inhibitor is the first appropriate choice. And that's really based on that slide that I showed you comparing the RESONATE-2 outcomes to the CLL14 outcomes and to the shorter progression-free survival that is seen in the fixed duration therapy strategy compared to the continuous therapy. I also am fearful of TP53 aberrated CLL that needs treatment. When those patients progress, there is a higher risk for them to progress with Richter's transformation. And I think we've all had the experience of seeing patients who are on novel therapies that for various reasons had to come off and then very rapidly progress to a Richter's transformation after that. So I think that continuous therapy with a BTK inhibitor is the most appropriate in that setting. I think there's not really sufficient data maturity to show what happens in these patients with ibrutinib plus venetoclax combinations. I think CLL13 is going to hopefully provide that answer relatively soon. There's another trial that has finished recruiting, the CLL17 trial, that compares fixed duration strategies to continuous therapy strategies. But I think they'll have to wait a number of years for that data to be sufficiently matured to allow us to inform that particular decision. When it comes to patients with IGHV unmutated CLL, I think there's less of a clear difference between the trials in that setting. And I think, again, in the South African setting where we do need to be cost conscious, we can't give continuous therapy to everybody. I think fixed dose combination with venetoclax and obinutuzumab is appropriate. The question is whether a fixed dose therapy combination with venetoclax and ibrutinib may have an advantage. It doesn't look like it from the data from CLL13 that's available so far, but we'll see if that changes with time. If you have a patient who, for whatever reason, cannot tolerate or cannot have access to a venetoclax and obinutuzumab combination, or it's a patient who lives far from your center, then obviously a BTK inhibitor is a good alternative there. And I think really the venetoclax obinutuzumab outcomes in IGHV mutated CLL are magnificent. So I think that's really the most appropriate therapy there. There is E1912 that shows a little bit of a better outcome with ibrutinib plus rituximab, but I think that difference is small. And again, in our setting in South Africa, a fixed duration therapy is probably more cost conscious. If you have a patient who doesn't have access to any of the above mentioned combinations, remember that FCR still produces very good outcomes in patients with IGHV mutated CLL. R-Bender has shown to have equivalent overall survival, even in these trials looking at the newer combination therapies. So I think it's really feasible where these are not accessible. Of course, the answer is always put a patient on a clinical trial where you can, and there is some good news in that regard, which I'll come to in a moment. So there are 2 clinical trials which have started up in South Africa. This list on the left-hand side is incomplete. I got an email from MSD just as I was starting to present to say there are 3 sites active in Gauteng in the first 2 of these trials on the right-hand side, and there is also a center active in Bloemfontein. These are MSD trials, the 008 trial. All of them are looking at this new molecule, which is nemtabrutinib. I'll tell you more about nemtabrutinib. It's a 2nd generation BTK inhibitor in a moment. The 008 trial is looking at nemtabrutinib versus chemoimmunotherapy. So they exclude TP53 aberrations from that trial, but they do include IGHV. And the comparator arm is either FCR or R-Bender, and that's investigator choice based on age and comorbidities. The 2nd trial is a 2nd-line trial, and that's a study to compare nemtabrutinib plus venetoclax versus venetoclax plus rituximab in 2nd or subsequent line therapy. The 3rd trial, we are hoping South Africa will be selected as a country to participate, and all of the sites participating in the 1st trial will also have the 3rd trial if it is selected. That's a very exciting trial. It's also the 1st or 2nd line trial comparing nemtabrutinib to ibrutinib as either 1st line or 2nd line therapy, but we'll only know a little bit later this year whether South Africa has been selected to participate in that trial. So a number of centers around the country that are available. If you have patients that you think might benefit from being included in these trials, then please refer them appropriately. What are the new horizons in CLL? So I think really what's going to be interesting to see is what is the combination data like acalabrutinib and zanubrutinib combinations with venetoclax. Some of these trials have completed recruitment, and we're waiting for data maturity. So hopefully we'll see those results in the next year or 2. And then, of course, there is the very exciting 2nd generation BTK inhibitors. Probably the best known one is a drug called pirtobrutinib. So just to show you this diagram on the right-hand side, ibrutinib, acalabrutinib, and zanubrutinib are all irreversible covalent binders to the BTK enzyme. And they bind at 2 sites. The important site is the C481 site. And when patients develop resistance, with CLL develops resistance to these 1st generation BTK inhibitors, it happens on the basis of mutations in the C481 site. Therein lies the advantage of these 2nd generation BTK inhibitors, of which pirtobrutinib was the 1st. They are non-covalent binders, which are reversible binders to BTK, so they can overcome this resistance conferred by mutations in C481. So nemtabrutinib is this MK1026 molecule, so that's the trial that will be available in South Africa for recruitment. Right, so that brings me to the end of this presentation. I hope that you've enjoyed it, and I hope that there are 1 or 2 new things that have been learned. I'm eager to hear if anybody has any opinions on the comparisons that I've raised here, and I'll happily take any questions now. Thanks for your attention.
Thank you, Michael. That was a mouthful, but I'm sure everyone enjoyed it just like I did. I mean, there's still short of 90 people at this stage listening. Any questions? Anyone that wants to ask Michael something? Michael, did you just from my side, when you read up, and especially with regard to the combination therapies of the BTKs and venetoclax plus or minus anti-CD20s, are they designing the trials like the CLL17 and those trials now to try and make them response-based with regards to MRD negativity or positivity, just to try and save costs, or is it just throw the kitchen sink for as long as possible? Or how do they design these trials? Bit of an unfair question, but I mean, I don't know if you've read up something about that.
Yeah, so both CLL17 and some of the other comparator trials do have a continuous therapy arm with monotherapy with the BTK inhibitor, usually ibrutinib. So for that reason, MRD negativity has not been sort of a significant marker in terms of comparison. They do measure MRD negativity in the patients treated with the combination therapies, I think as part of the study, but there's no, I don't know if you remember the, I've forgotten the name of the trial now. It was a second line trial that was done in the UK, combination of venetoclax and ibrutinib for second or subsequent line therapy with CLL, and actually used MRD negativity as a decision maker as when to stop therapy. So there's no component like that in this trial. They receive a fixed duration of 12 months of the venetoclax and ibrutinib, and then they stop. They measure MRD status, but it's not used to take decisions. Sorry, that was a long answer to your question.
Thanks. Anyone else? Great. Thank you. Thank you so much, Michael. And thanks everyone for tuning in. Next week, as we said, is intermediate risk AML, so that will also be a mouthful. And thanks for all the trouble, Michael. It was really a great talk. As we said in the beginning, the talks are available on Blood SA's website if anyone missed it or anyone wants to recap. Again, also all the best to all the fellows that are busy with their exams this week, today, tomorrow, and on Wednesday. We wish you guys all the best for the rest of the exam. All right. Have a good evening, everyone. See you guys next week.